let's start. It's a great privilege and honor to introduce my faculty and good friend, Christoph Hofstetter. Christoph has a very impressive career. As of July 1st, he will be a professor of neurological surgery at UW-Medicine, and he was elected to the Sherry Raceback endowed chair in neurological surgery. And this is a great story because it's a person he operated on who was so amazingly grateful that she endowed a chair on his behalf. Christoph is a true triple threat. He grew up in St. Pölten, Austria. He went on to get his MD and his PhD. He got his PhD at none other than the world-renowned Karolinska Institute. I didn't know do you have to speak Swedish to get your PhD there, or you speak German? Are you allowed to speak?
Jo, vi snackar svenska.
Yeah, okay. So, well, how to speak English, German, French, everything. Anyway, and he's gone on to have a brilliant academic career. He did his pre-residency fellowship at Mayo Clinic. Fred Meyer still talks about him as being a wonderful student, and he did great. Then he went to Cornell, where he did his residency. He did his fellowship in Miami in minimally invasive surgery, and really has helped pioneer a new field of endoscopic minimally invasive surgery. He's one of the world's leading experts, and his research interests vary a little from that. Interestingly, he's an expert in spinal cord injury. He's both a PI of DoD grants. He's the PI of an R01, and he helped his PhD partner Zin. She's also an R01 holder. He has an impact factor of almost 40, H factor of almost 40 already, and he has published over 100 papers in countless journals. So that's where Christoph is now. I look forward to welcoming you, as a professor, July 1st. So congratulations, Christoph, and the Sherry Raceback endowed chair. So go ahead.
Wow. Rich, I want to share my screen here right now. Just wanted to thank you for that kind invitation, but also thank you for leading us through these times. I couldn't envision a better chairman and a better department. Every day I come in here, I'm astounded how you do that and how my colleagues and everybody does it. But it's been more than an honor to be part of this. So thank you first. Here are my disclosures. As you guys know, I do a lot of teaching. I like consulting. I like development and moving the field forward. None of that should really influence the talk, but I'll be very frank and open with that. So here's the outlay. It's a ars vivendi means the art to see in Latin, and a lot of the stuff that I've been doing in my research has been trying to enable us to see things, both in the laboratory where we want to sort of develop new ultrasound technology to see blood vessels, to see blood hemodynamic changes, and explore their indications in spinal surgery, as well as to enhance the visualization of our surgical interventions, in particular spine surgery, which I'm specialized in. And then we want to gain insight in how these new developments change our practice, because in the end of the day, what we're interested in, how can we advance the field? How can we make things better for our patients? That's what it's all about. Again, I know this is Zoom, so some people, only wear shirts, no trousers. Other people wear nothing, and so I totally understand that that's new times. So here we go. The outlay is here. So let's start with ultrasound. So let's start with a case, 65-year-old female. She presented, I think, now 2 years ago to the ER after a low velocity motorbike accident. She had a C2 teardrop fracture. It was Asia A with a C4 sensory level. We performed an acute decompression and stabilization. And the question was, how is this lady going to do? Right? She was Asia A complete. And so very acutely, how do you counsel the patient? How do you counsel the family? As we know that a fourth of these patients recover at least one Asia grade. And that's everything we know. But some people recover more. So let's go back there. The importance of the microcirculation. Again, our tissue in our bodies can only survive and is only vital if it gets supplied with oxygen that we need continuously. And so almost all surgeons here in this department, we're making sure that the brain tissue gets blood supply. That's kind of, in the end of the day, what all of us are doing. Ischemia and infarcts are commonly seen with traumatic injury, both of the brain and the spinal cord. Ischemia plays a critical role in the propagation of secondary injury. And I'll have a lot of very impressive data on the secondary injury that we can now really sort of see in great detail. But however, so far we have no biomarker for the spinal cord for tissue perfusion. And I just wanted to refer to my colleagues in vascular surgery. Their entire field was changed, revolutionized really by developing these perfusion biomarkers that is done with CT perfusion. Here's a little overview of the spinal cord and its vascular supply. So we have anterior trunks and anterior spinal artery here, number 2. We have a posterior spinal artery, and then they form a pedal plexus and the central arteries. And you're going to see a lot of pictures of these central perforating arteries in the middle that sort of go that sort of perpendicular off the anterior spinal artery. Here, a big shout out to Matt Bruce. He's the physicist that we have had the great pleasure and honor working with. What he has been instrumental is getting this new technology to our laboratory. And on the left side, we see a conventional Doppler that we have it right now in the OR. And this is what you see with blood vessels in a rodent. Conventional ultrasound shoots individual pulses into the field, and then having individual pulses, it puts together a picture. Plane wave works differently. It actually shoots down different waves that cover the entire field in different angles. And by doing so in different angles, then you can reconstitute the image. The big advantage of this is you can have many, many more images. And so just to give you an idea, with conventional ultrasound, you can get maybe a frame rate of 40 or 50 a second. With plane wave, we get 150,000 and even more per second. So we can get a magnitude more material. So this information we can now use. And what do we use it for? Well, if you look at the blood flow, most of the tissue perfusion happens in those very low flow capillaries and arterioles that supply the tissue with oxygen. And so how do we get a hold of that? Because if you look at the velocity, the velocity is much larger in the larger arteries. Up here we see the velocity is here, the white line is velocity, and the blood volume is in the yellow line, the cross-sectional area. And so we want to image that blood volume that is in the capillaries and the venules to see how much blood is supplied to the tissue. And so here's where this new technology now comes in, where we can use these little microbubbles, and all the residents have seen that. We use it for our patients with spinal cord injury. Microbubbles are very, very small. They're almost like salad dressing in that they have a shell made of lipids. Can also be polymers. Have a core with heavy gas, and you have to activate them. So we saw yesterday what happens if you don't activate them. And then what it does is they have a resonance frequency. So with other words, if the ultrasound frequency of the sound that you deliver to the tissue matches the resonance frequency of the bubbles, you get an amazing signal to noise ratio back. In fact, it's so strong that you can see individual bubbles, and there's no other contrast that can do that. So that the contrast that you get back is amazing, and the signal to noise ratio is unique. And again, Matt Bruce, as mentioned before, what we did here, the unique thing here, and I'm sure I'm not 100% describing it correctly, but so we have these non-linear pulsing sequences which means nonlinear means because it's either or, right? You either get the resonance frequency of these bubbles or not. So it's nonlinear because it's an on-off. And then you combine this with plane wave acquisition, 150,000 slides a second, and then process the tissue, the signal, with higher values and lower values. And that, what we can do there is we can distinguish the perfusion and the blood flow. And so this is what that looks like. So this is a rat spinal cord. On the left side, you see the low velocity flow. On the right side, you see the high velocity flow. And you can see how different areas fill up in a different fashion. You can also see how different areas around the injury appear in different ways. And again, we get back to this as this is going to be very important for us to better utilize this technique. Big shout out to Jennifer in my laboratory. I've had the great fortune to work with her in the laboratory. She's a physicist PhD and has been instrumental in developing this super resolution imaging technology. You can see here, compared to the previous slide, how much gains we have. Basically, super resolution assigns a centroid to each of the bubbles and then reconstructs the image. And as you can see here, you get much better resolution. And just to give you an immediate implication and application for this is what Dr. Kine in my lab did here was we looked at the spinal cord, and you can see here these perforating arteries. Those are sagittal images of a rat spinal cord. Here is ventral, here is dorsal. Here's the perforating arteries supplying the spinal cord. And again, that's a median section through the spinal cord. And what we can see there nicely is that after injury, looking at super resolution of those images, you can see how these vessels bow away. They make space. As we have a mass effect from this hemorrhagic necrotic core, and the vessels bent away, very much like we see in an intraparenchymal hemorrhage in the brain, where there's mass effect in the surrounding tissue. And we can measure that now by looking at individual little intrinsic spinal cord blood vessels, and we can see how these vessels deviate from the center of the lesion. And we evaluated that and we measured that, and you can see how these angles change 1 hour after spinal cord injury. So indicating that there's indeed mass effect at a spinal cord injury lesion. And it gets even more fascinating. This is data that we have never known about, and nobody ever has seen this. So looking at the cervical spinal cord, you see the central intrinsic arteries that are both caudally, as they're both perpendicular, but a slightly caudal here. And so what happens if an injury expands the tissue is that since they're almost perpendicular, slightly caudal, the vessels can bend to both sides, both rostrally and both caudally. And we see the injury expansion of cervical spinal cord, both rostral and both caudal. And that is very different in the thoracic spinal cord, where the vessels are rostrally inclining to start with. And then with injury, they actually have only one way to go, and they can bend caudally. So this was a very intriguing finding for our laboratory. You can't wake up John, but for me, it's really important because this tells me that we have an opportunity here right now to maybe address that mass effect in the cervical cord and potentially save 1 or 2 segments in the cervical spinal cord in a patient. And that would potentially have a huge clinical impact. So I'm extremely excited about this new finding. And again, there's no other technology where you could really sort of see that. So big shout out to Jen. She really was very, very careful and very thorough to do this analysis. Back to contrast enhanced ultrasound. We have done a lot of work, and again, a big shout out to Sin Kine, Dr. Kine. She has been really instrumental to develop this. Our animals undergo a crush injury of the thoracic spine. Again, I could give a talk about how representative this is. I think for some injuries it is, other ones not as much. And again, all the residents that we have done this in the OR with will attest to that. And then we do a high frequency ultrasound, and we do rigorous behavioral testing. Here, just a little overview is what do we see immediately after injury. There is changes in vascular parameters. Given that we have this vast amount of data, we can now calculate all different parameters, including rise time, which you can see that the rise time increases. So after injury, it takes more time for the blood to get to the tissue, and it's quite significant, as you can see, and almost seems to be a global change. And then the area under the curve changes, and that changes dramatically. As you can see, at 3 days after the injury, we have a tremendous amount of blood volume and in that area. So there's hyperemia in the injury area after spinal cord injury, and we'll get back to that too. Also a very novel finding that don't quite know what to do with that yet. So when we have spinal cord injury, there is disruption of perfusion. There's a critical loss of perfusion. Again, in this animal model, it's 2.2 millimeters, square millimeters. And we can see necrosis in the histology in the area that we see the loss of perfusion. If we plot out those areas, the perfusion area, the area of deficit, the perfusion area deficit, compared to the BBB score, which is a hind limb motor score. It's a score where we can rate the locomotion of the patient's hind limbs. We can see that there's a fairly good correlation there with an R square of 0.76 and highly significant. So the bigger the area of deficit, the less well the animals do. 21 is the maximum. That's a normal walking rat. 10 is where they start weight bearing. So we can see that there's a nice correlation with that. So the bigger the area, the less well the animals do. Another thing is that we can see there is how this changes. I mentioned before secondary injury, and you can see from acute to 3 days post-injury, you can see how this area increases in size, and only after 14 days you can see a decrease, but you can also see a decrease of the area of the spinal cord. So the atrophy of the spinal cord has started there already, as we lose tissue after an injury like that. What we can see here in a larger study here is that the perfusion area deficit correlates nicely with injury severity. So you see that on those bar graphs, the more severe the injury, the larger the deficit. And importantly, the perfusion area deficit correlates here with more animal with the outcome at 8 weeks. So the chronic motor outcome, both of the locomotion scoring with BBB, as well as the ladder walk, where the animal sort of walks along a ladder and we count the missteps. And there's a new marker that we developed, which I think is very different from anything else that we have ever had in the spinal cord, as it is the only biomarker that actually looks at viable tissue. If you look at any other biomarker in spinal cord injury, all spinal cord injury biomarkers look at tissue that has been lost, like the perfusion area deficit. This is the very first biomarker that actually looks at tissue that is still viable. And so we call this the spinal perfusion index. Again, there was and they measured basically the perfusion of the slide to the spinal cord in the center in relation to the periphery. And then we get an index. And it's very, very quick to do that. We can do that in an hour. It takes 2-3 minutes, and you have that marker. And you can see this perfusion index also correlates very nicely with the injury severity, in saying that the most severe ones have the smallest index, as they have the least amount of blood and blood supply in that area of the injury. And you can see here again with the outcome at 8 weeks, same thing again, R square 0.65 and highly significant there. So it can predict the functional outcome in rodents with mild, moderate, and severe spinal cord injuries. So what about our patients? So we have done 20 patients so far with acute traumatic injury. Most of them were Asia A, so complete. The rest was Asia C and Asia D. And we performed intraoperative ultrasound. Again, this was work supported with a DoD grant that we got just renewed for another 3 years. This is what it looks like. So we inject anesthesia is kind enough to inject contrast, and you can see here the microbubbles coming in. Here's rostral on the left side, here's caudal, and you see a large area of hypoperfusion. Then we go ahead and we put these markers in there at the maximum area of hypoperfusion and compare them with the periphery and calculate our index. And another thing that we can calculate is the perfusion area deficit. So here's outlined in red here, like we did in our rodents. And you can see Sanan has done a lot of measurements, so shout out to Sanan. And we can see that the area perfusion deficit is larger in patients with Asia A compared to with patients in Asia D patients. Again, significant correlation with that. And then we also did the same with the perfusion index, and you can see that the perfusion index is actually a much stronger positive, shows a much stronger positive correlation with Asia grade with 0.89 and highly significant in those 20 patients. And that's the difference between the complete and the incomplete patients. And where the SPI is 0.3 incompletes and 1.3. And this is something that is really remarkable and has surprised all of us, is that the patients that have incomplete spinal cord injuries, Asia Cs and in particular Asia Ds, they actually don't have a loss of perfusion. Quite the opposite. They have hyperemia at the site. And that was something that we really did not expect, and that, again, is not described in the literature so far. So this data is totally novel. And it really makes you wonder if our current parameters of treating these patients is correct, as we have patients that have an absolute loss of perfusion and other patients that pump in almost twice as much blood into the injury site. If we can all treat them with the same protocol, I would like to very much question that. And so I think this is going to be the beginning of a much smarter approach towards spinal cord injury care. And the other nice thing is that in rodents, the spinal cord injury index and the perfusion area deficit correlate extremely well. In humans, that's actually the correlation is much worse. And what that tells me is that the perfusion area deficit, with other words, the spinal cord injury, the spinal cord tissue that we have lost, as you can see with a couple outliers here, does not necessarily correlate as well with the outcome, as it doesn't hone in the fact of what area is eloquent of the spinal cord. So with other words, what spinal cord area needs to carry function versus spinal cord that we can spare or that is not as involved in function. So we'll keep you posted on this, but I think we are onto something really good there, as we can now very, very nicely distinguish different types of spinal cord injury. What are the indications? Well, you'll come back to this patient that I started with, 65-year-old female, Asia A, and we can see her ultrasound. You can see that she had a loss of perfusion, but her index was, I think, 0.7, 0.8. So it was decreased, but not to a dramatic point. And in fact, she did regain a little bit of hand movement in her intrinsics and in her bilateral lower extremities. However, the patient and her family said that she would not be happy with incomplete recovery, and they decided to withdraw care. And I think this is an example where a biomarker that is reliable comes in, right, to make a decision. Was that the right decision for this patient and her family? Looking at the scan, I'm still not sure. But again, it's research, and we couldn't make any more strong recommendations. Certainly, leaves a sour aftertaste there. Big shout out to Ariana Barkley, who's now a superstar in pediatrics neurosurgery. So she wrote up a paper on utilizing this very same technology for intrinsic spinal cord tumors, a series that we published: hemangioblastomas, polycystic astrocytomas, epidermomas, and subepidermomas. And the interesting thing about this technology is you can see this blood supply really nicely in the boundary. So it's very very helpful technique for resecting these neoplasms. Here's a little example, and especially you can see this is a ependymoma, and you can see the vascular supply really nicely. And what this does, it just speeds up the surgery quite a bit because you can just work towards that vascular supply, and then you know exactly where to expect that. All right, so that was the first half of my talk, and I'm right in the middle of it, of the hour. And I see that everybody is just biting on their nails. And then the rest of the talk is going to be about endoscopic spine surgery and how we have really pushed the field forward at the University of Washington with this. Everything dates back to my collaboration and my colleagues at the AO Spine, where we thought about what minimally invasive spine surgery means. And it's not about the size of an incision, not the bandage, but it really, the goal of minimally invasive surgery is to develop technologies that reduce the local tissue damage, so do less damage during a surgery, and the systemic stress. And that's what it's all about. And in fact, every good surgeon should be a minimally invasive surgery because those are sort of interests that to hurt the patient the least should be in all of our interest. You guys know that I'm using these endoscopes for some of my spine surgeries. They are like an coaxial tubular structure. They have different systems, different sort of components. There's an optical system in there. It's a rod lens, and that's something that is also on the way out. Rod lens systems are here for another couple of years, but then afterwards there's going to be a chip on the tip technology. There is an illumination where right now there's light fibers, but again, the next generation is going to be LED. There's an irrigation channel and a working channel. And again, just mentioning the things that I know on the pipeline, I've been testing them at different companies. There is so much innovation in this field. It's amazing. Just to give you an idea, an endoscope like this has 300 parts. So next time you slam it on the table, just think about that. This is something that I see residents and fellows struggle all the time. It's the tubular retractor, as you have to maneuver that with your left hand, that you also hold the endoscope. It does a lot of things. It prevents the operative field from tissue creep, as you don't enter a cavity with this type of surgery. We have to create a cavity. We have to protect that cavity. We use it as an elevator, so meaning that we can move tissues and scrape them off bone. You can also use them to retract structures, and all of this has to be done with your index and your pinky of your left hand. And there's a lot of learning curve to that. And basically, the first 10 cases is everything that I'm trying to teach the residents and fellows how to do that. Here, the comparison, I've heard many times from my colleagues, well, MIS, it's all the same, right? Microscope, endoscope, who cares? It's actually quite different. Working distance microscope is 300 millimeters, endoscope 3 millimeters. So the visualization and the illumination is right at the target. The field of view is restricted. Anybody who has done metrics, decompressions metrics, T-lifts, again, which a handful of people in the audience have done here right now, they know that it gets very difficult to do MIS surgery once the patient is bigger. 8 centimeters plus becomes a struggle. With the endoscope, it really doesn't matter. We have a wide panoramic field, and we can visualize no matter how deep the patient is. Line of sight is straight, it's off axis, 3D with the microscope, 2D with the endoscope, and different tools and different way to work with. There's typically only one tool that goes in, but again, we have the tubular retractor. We can also use the irrigation channels for additional tools. Visualization, it's a totally different way to visualize the tissue. As you see on the left side, it's microscopic. That's how I was trained by Dr. Hartle at Cornell and Mike Wang. We did everything with the microscope. You can see here the dural structures bulging on the right side. You see nice tissue control as everything is underneath the water and submerged. And so you can see the panoramic visualization, the off-axis and the tube is much more narrow. It allows you to get away with less bone removal. This is really where the endoscope comes in handy, the contra level decompression. This is something that is extremely difficult to teach, as one wrong move wraps up the entire caudate equina and you have a paralyzed patient. So with 80,000 RPMs in your hands, there's no room for error there. With the endoscope, as you can see, the irrigation pushes the neural elements away, and very nicely and safely allows you to do this contra level decompression. And you can estimate and see here how rudimentary and how difficult it is to do precise work, and how you can really shave to the millimeter here because everything is under control. So it's a totally different level of precision, and they will see afterwards in the results that sort of mirrored there. Another nice thing about the endoscope, it gives us a new corridor into the spine, the transforaminal corridor here, again, a transforaminal view, the caudal index level pedicle here, the SAP, partially removed by the foraminoplasty. And that's a corridor that you don't have as a surgeon if you don't do endoscopic spine surgery. Then you only have the interlaminar approach that is typically taught. So it immediately increases the corridors into the spinal canal. And what this is good for is access to the foramen, lateral recess, and especially central discs. Now, let's look at the utilization of this worldwide. We published a paper on this, looking at the articles published, and you can see that these technologies are most prevalent in China and South Korea, but the US is really picking up quite quickly, and we see it, our fellows are not struggling for jobs, so they have all 5, 6, 7 good job offers. Why does not everybody do that? Published a study on that too. Surveyed some spine surgeons. So 50% of them performed endoscopic spine surgeries. The barriers were lack of mentorship. It's difficult to learn. There's a lot of different parts. There's lack of technology. You have to buy the towers, and the endoscopes, again, compared to microscopes, those are peanuts. A modern microscope is $500,000. An endoscope tower is $250,000. So it's much cheaper, but it's still capital. Suitable surgical indications, I think that's something that is there needs to be more education done and perceived as too risky. So those were the barriers to adoption. How long does it take to learn? We published a paper on that too, compared to fellowship-trained spine surgeons. And we looked at the posterior cervical foraminotomy as an example, and we found that with extensive experience, the plateau with a new procedure is approximately 9 cases. Without extensive experience, it's around 30 cases. So if you have expertise in endoscopic spine surgery, you can pick up any new technology or any new indication or new approach in around 10 cases. If you've never done endoscopy, it will take you 30 cases where you take more time. Interestingly, the learning curve has no impact on the outcomes or complications. So even in those 9 cases or 29 cases during the learning curve, the outcomes are the same and the complications are not elevated in this series. What we have done here is we have evolved the endoscopic surgeries at the University of Washington from a blind procedure where there was initially targeted in the center of the disc. Over the years, it has moved back into the foramen, the Camden's triangle, where the Camden's triangle is targeted in a blind fashion, guided only by fluoroscopy. And that leaves you with a 2 to 5% chance of radiculopathy. As you can imagine, in some patients, the nerve root is going to be more caudal. In some patients, the foramen is not very big. And for this reason, we are adding a foraminoplasty, which is a funny word. I know I don't like it either, but foraminoplasty means that you are resecting part of the SAP, very much as with a transphenoidal, endoscopic transphenoidal, you're resecting the posterior septum to create space. So it's a very similar idea that you have to create space for your endoscope. And then the latest iteration is that we don't enter the foramen blindly anymore, but actually target the superior articular process. We call it a trans-SAP approach. And we published that approach. It was Bree who helped us with this publication of the residents. Looked at 40 patients with the trans SAP. Importantly, no instability on flexion extension, and we looked at outcomes up to 24 months. Here's some operative details that we don't have to go over here. But at 24 months, we saw significant improvements of the back pain in these patients, so from 55 to a little bit below 20, so more than twice the relief of pain, and also as well as the leg pain, which decreased from 88% reached a minimally important clinical difference for the ODI and 75 for the leg pain, meaning that it was meaningful and did meaningful improvement. And these are the adverse outcomes. 2 required a medial branch denervation, and 1 required a corticosteroid injection. So quite good outcomes there. We also published on this, showing Lynn McGrath was on this paper, that this technology is feasible in patients with mild deformity up to 20 degrees, where we also see, again, somewhat less of an improvement of leg pain, but still meaningful improvement of leg pain. So what can we do with that, and how does it change our indications for surgeries? One of my fellows, Dr. Saqib Hassan, helped with that idea with that paper. And what we found is, looking through the literature, is that the benefit of this procedure is really depends on the complexity. I'm sure there's, when I talk to surgeons, everybody's, people are like, well, I do fairly good discectomies, and that's kind of bread and butter, unimportant spine surgery. Anyhow, who cares? I can do this with a tube. I can do this with a Galpi retractor. And that's true for discectomy. So if you want to be a simple bread and butter spine surgeon and do only spines endoscopic, or you only want to do discectomies, the difference of complications is minimal. It's like 3% in this sort of in the best data that we have right now. So endoscopic spine surgery has 10% complications. Traditional has 13%. So with very simple procedures, the benefit of endoscopic spine surgery is significant, but small. And those are these little surgeries. So for example, a 29-year-old female with this caudally migrated disc herniation here right now. Just a little bit of an intraoperative video. I'll fast forward here right now. Here's the neural elements. Left is rostral caudal. Here we get an axilla. We're resecting the disc herniation here right now. And then in the end, we can inspect the neural elements. So that's interlaminar discectomy here right now. And here's a transfemoral discectomy, again, an approach that is only possible with an endoscope. 23-year-old male here. And you can see here, we're working on the SAP. So this is still part of the foraminoplasty, opening up the lateral recess, finding the disc, resecting the disc here. And then we can inspect the nerve root once the disc is removed, explore the annular tear, inspect the neural elements. Up here, you see that we should see the traversing nerve root here in a second. Once the gel foam is blown off, so here's the pedicle, here's the traversing nerve root, all visualized. And again, the contribution that we had at the UW for this is that the reason why the AO spine, which is a very conservative group of surgeons, accepted this endoscopic technique, because we married minimal invasive surgery with endoscopic spine surgery, and so everything is visualized. There's no more guessing, and there's nothing that is blind. And so this is patient now, again, with the Spine Healthy Tracker, 3 months follow-up. As patients have resolved, he's back at training. Sanan published a nice publication on this. We worked together with the Huskies and made a protocol for them. So taking care of quite a lot of the college athletes. And again, they go back at 2 weeks to biking, HydroWorks, and then almost to full advanced core at 6 to 10 weeks. So a fairly aggressive rehabilitation protocol. And so far we have been very lucky, and the Huskies have done exceptionally well. So let's move up on the complexity scale on laminectomies. So here's, for example, an example of a firefighter. He had L3, L4 spinal stenosis, typical neurogenic claudication. You can see the tight stenosis there. took him to the OR, did an endoscopic decompression. Again, this is what it looks like underwater. Left side is rostral caudal. You can see the burr removing some of the lamina, undercutting that. And again, it's a very special technique as the movement comes from both the left and the right hand. We're stripping off the yellow ligament and starting to get to the neural elements. And here we go. We see rostral is left upper side, and we're taking a couple kerosene bites off the yellow ligament and taking out a yellow ligament, and then you see it happened, right? So here is the famous dural tear here right now. And what do we do about that? So big shout out here to Maddie. We actually wrote up a unique, world first ever, it's actually true, bimanual technique for working channel endoscopes, where we have made a little contraption, just a K-wire, a guide wire that we put through the irrigation channel, and can then work together with the tools through the working channel. And you can see here the pledget coming in here, where we do the inlay graft and then can stabilize it with the other hand. So you can see here this little hook that comes in there that helps us to hold it in place. So we have a bimanual technique to repair this. And we looked at 174 patients undergoing endoscopic decompressions. Importantly, when we did this repair, the patient-reported outcomes were not impacted. And the only thing we saw is the length of stay was increased significantly. But otherwise, this is a safe technique to repair that. And you can see how we tucked it in here. Once it's tucked in with those two tools, we can go in and sort of put some seal in there and glue it and hold it in space. Again, if that's done this way, then there's no impact on surgical outcome. As was the case for this patient, he sent me this email 2 weeks afterwards, slow response, pain is getting stronger. I rock climbed for 1.5 hours on Monday. So this was 2 weeks after surgery with the dural tear that you saw. No extra pain in my back afterwards. And here's his still paper outcome. That was before COVID. Lynn put this paper together on outcomes of the endoscopic laminectomies. That was the beginning of our learning curve, mainly 1 and 2 level surgeries. What we found is surgical times were longer for endoscopics. At that point, it still took us, 3 hours versus MIS decompressions, 2 hours, significantly longer. But the hospital stay was already shorter. And importantly, the outcomes at 12 months were better for the endoscopic cohort. And that was remarkable for me because I have done thousands of MIS decompressions during my training and afterwards fellowship and early during my being a faculty. And I was surprised that the first 50 endoscopic decompressions had better outcomes than the last 50 of my MIS surgeries. As you can see, ODI was better in the endoscopic ones, back pain was better, and the leg pain. So these patients just did better. And there was the beginning of learning curve. And also, they had fewer complications from 26 to 8%. And this is a picture that before you sign up for traditional surgery, you should think about that. The nice thing about endoscopic surgery, given the small size, it preserves your facet joints. As you can see, it's a triangular shape. And here's the panoramic visualization, which we see, preserving the elements. And again, like we said in the beginning, that's part of what we want to do with minimal invasive spine surgery. Maddie helped putting this paper together, so thank you for that, where we showed that another nice thing is that as we have more and more obese patients, we can see that obesity has now no effect on operative time because the endoscope is down at the field, has no effect on functional outcome, no effect on intraoperative complications. So we still see an increased induction time. It takes us more time to intubate a larger patient. It takes more time to position a patient. There's a prolonged hospital stay and increased medical complications. But everything we can do from a surgeon's perspective is now almost neutralized. So we have been taking care of a lot of these more obese patients. And again, at least from a surgical perspective, we can now treat them quite similar and have leveled the play field. And that's obviously now in the more complex procedures where endoscopic spine surgery has a complication rate of about 9% and traditional surgery 34%. So if you're specialized in spine surgery, and again, it's a gigantic field with almost 200 different procedures that we do, then you see the benefits now coming in with more complex procedures such as laminectomies. Now, people might say that laminectomy is not a complex procedure. Sure, it's not a complex procedure if you want to have poor outcomes. But I think to really do it thorough and well is quite complex. And then here's the rare, more complex cases where I think there's no doubt and where this has been really a game changer for us and our patients. And I think the hospital recognizes that we can take care of patients that really have no meaningful option otherwise. For example, this patient, a 45-year-old female that I took care of, BMI of 60, morbidly obese. You can see on the T-shirt she has a CSF leak here. She has had multiple plastic surgery revisions, was miserable. ODI of 50, so it means severely disabled, lower extremity pain and weakness. And you can see that she had at an outside hospital with ankylosing spondylitis, a short fusion construct. And I think even the junior residents will recognize here right now for an ankylosing spondylitis patient that this is not an appropriate construct. She had developed this Charcot joint there with hypergrowth and severe stenosis. So in my traditional toolbox, I really have nothing to offer for this patient, which is not going to end the disaster. So I could do a retropleural approach, which is going to lead to a probably lifelong CSF leak into the pleural cavity, which is difficult to treat and sometimes requires transplantation of the omentum myome. You could do a posterior revision surgery, which has been operated on 4 or 5 times, has been infected. Its leaking would be a disaster in terms of wound closure. So that's a wound vac here with CSF drainage. So really no good option. And so this is where the endoscopy comes in and where we can treat patients that nobody else can really treat with such low morbidity. You can see here how it decompresses the spinal cord, endoscopic. You can see the spinal cord right ahead of us, and we can do a circumferential decompression. You can see the edge of the dura, spinal cord, and then we repair that dural tear with a piece of DuraGen. We did have one complication in this patient. We put a graft in there. During the graft placement, this space was also communicating with the pleural cavity, so we had a pneumothorax that was really unavoidable because everything was just open and communicating. But we treated it with a chest tube, and she's now 12 months out, has obtained a solid arthrodesis, is able to ambulate, and had a reasonable outcome without any major complications. Another surgery that has been a game changer is this cervical decompression surgery in our aging population. This is, for example, an 84-year-old patient, cancer patient, severe stenosis C2, C3. Obviously, as the fellows and other spine surgeons in the audience might notice, has a cervical deformity. But again, 84 years old, we don't want to think about deformity surgery in a patient like that. That would be a horrible outcome to get go. And so these patients now we can treat with decompression surgeries. And the most rewarding thing about these is now these are the patients that really start walking again. So you can see in the Spine Healthy app that we use to monitor, you can see every day how they, after surgery, perk up again. The neck pain actually gets better, arm pain gets better, and they start walking. And so that's very rewarding to see that. And we put that up as a series. We looked at 23 patients, mean of 22 months of follow-up, and we saw that the JOA improved, the NURIC grade improved in these patients. And again, for the very first time, we also published here a paper showing that we can do these cervical decompressions that I used to put into the ICU. We can do now as outpatient surgeries with virtual follow-up and continuous monitoring. So these patients are not using any more hospital resources after their surgeries. And a quick top off here right now, a case that we did with Mike here, a 22-year-old male who had this avulsion fracture here right now. Again, that exemplifies a great collaboration with our vascular colleagues. He had strokes that he had because he pinched off the vertebral artery here with this little avulsion fracture. And again, as you can imagine, to get there with open surgical technique would be quite invasive. Here's the angiogram. You can see during right neck rotation how it gets pinched. And then here's the surgical, where we went in with the endoscope, and we're able to undercut that fragment and decompress this. And at the end, we're doing a little Doppler confirming that the vertebral artery is decompressed. You can see the Doppler probe in there and confirm that we have achieved the objective. And you can see on the postoperative CT scan, here's preoperative, postoperative, that we resected this protruding bone spur there. And again, this is the impact on the patient. These are daily outcomes. So we cost this patient 1 day of neck pain and 1 week of increased neck disability. So with the results here, that what he told me in the chat function, no more events, no more problems turning my head. So that's really the case, is the complexity that we are targeting here right now. That brings me to the last part of this talk. We have a couple more minutes before the hour. And here I wanted to show how implementing this technology has changed my surgical practice totally. I've shown that these are highly standardized procedures. A couple of years ago now, I put together a working paper, consensus paper with the AO Spine, defining these procedures, exactly how they're done, what needs to be done, and pretty much people in the world adhere to this now. So there's a nomenclature that is now used for most part. It's a very systematic approach. My Austrian heritage comes in handy, being a very careful and sort of systematic here right now. Here is, for example, the laminectomy procedure, ULBD, unilateral laminotomy for bilateral decompression. And these patients cannot be treated with outpatient. The hospital stays have decreased. So a lumbar discectomy traditionally is 1.4 days, and endoscopic is 0.7 days. A lumbar laminectomy is traditional 2.4 days and 0.7 endoscopic. And it becomes more obvious with more complexity. A lumbar TLIF, 4.8 days for 1.4 days. And you can see these on these patients. We can send them home quicker with these favorable operative, perioperative complications. We touched upon that. I'll fast forward through this right now a little bit. Total complication rates in 500 patients was 4.7%. I think this is one of my favorite papers that we published really right now, where we showed that in 1,261 endoscopic cases compared to 5,936 patients from the NESCRIC database, matched cohort, full endoscopic spine surgery has an infection rate of 0.001%, traditional about 1%. Again, you might say that 1% is not a lot. We've all seen people whose existence has been destroyed by an infection like that spiraled down. And so what we are delivering and providing our patients is 16-fold reduction of surgical site infections. So you go and you get a discectomy, you have a 1% chance of getting infection, 1% chance of having really your life destroyed. And we can decrease that by 16-fold. There's no way, back. This data is, again, I think one of the best papers we've published clinically. And that is also confirmed by this meta-analysis that found that approximately reduction of complication by 50%. And that brings us to the last point here right now, last few slides. What we saw is these patients are doing so well, they don't come back to the clinic. So only 58% of these patients show up to the clinic after these procedures. This was exacerbated by the COVID pandemic, where we had telemedicine visits, we had rapid turnover of personnel. So once you trained somebody to scan these outcome forms, they were gone again. And we didn't have anybody calling the patients. And so there is good data on the patient like the use of apps. It's patients like it because they can track the recovery, they have access to the surgeon, they don't have to come back to the hospital, and they can find some resources that helps them to recover. And here are the challenges, right? How do you make the technology easy enough for the ADE-ideal patient to sign up, and how do you make a simple interface that is self-explanatory? That's how we started 8 years ago to make a own homegrown app at the University of Washington. We call it Spine Healthy. We do all the surveys, virtual follow-up with them. And this is what it looks like. So we collect prompts, physiological monitoring step. We can chat to the patient, review images, and have virtual follow-up. There's a patient dashboard that tracks all of these different parameters. Here is the surgeon is putting in a lot of details about the surgery that we use for our study group to study outcomes, to quality initiatives, make things better. The patient can track the recovery after surgery. They see the stepping patterns. We also put a bunch of resources in there for patients, videos, text explanations about the surgeries. This is what I see every day from my surgeries. I just looked this morning from my patients last week, so we can track them there. Tobias Pratze put a paper together, and again, Sanan was there. A big shout out to James also, who has worked really put a lot of work into this. Here, 91% of patients, when asked, they elect this virtual follow-up. They want to do that. 85% provide at least one patient-reported outcome. And we have now prompts for 74% available. In 1 year, it's 80% right now. So 80% of our patients are compliant. And interestingly, 100% were compliant with the virtual follow-up. So really nobody wants to come back, wait 2 hours in clinic, me looking at the wound and be like, hey, the wound looks great. Nobody wants to do that anymore. Here we tested the app and how patients agreed to that, and basically 80% agreed that it was useful. The top priorities for patients we asked them was communication with the doctor. Surprise, surprise. They wanted physical therapy instructions, and they want to review the images. And all physical therapy instructions we're working on with Dr. Herman from physical therapy, but we'll be able to provide that. Here's a breakdown, and again, 80%, 85% slide from James Pan that I borrowed here. 85% found it useful, positive experience, and 76% would use it again. Here's a couple examples how granular this data is. So the patient here was doing well, had a flare up here right now, and we treated him with steroids. He did really well and donated quite a lot of money to this project. Other patient had a flare up. Again, I saw it on the app. I called the patient. We treated him with muscle cramps and relaxants, and we helped this patient. And this patient just did a flare up here. It was an unrelated fall, and she broke her femur. Again, she improved after that again. So concluding here right now, what we saw here, there's a significant reduction for inpatient follow-up, what that does for my practice. I have freed up a lot of ambulatory space now that I can use to see new patients that generate money for the hospital. I don't have to waste my time with seeing patients that are doing well anyhow, but I still get the feedback. Actually, there is less likely patients that use the app are less likely to be readmitted. So shout out to our readmission rates, which go into the USA reports of a hospital, and there is no increase of ED visits. So it's a safe way to manage these patients. And we have expanded this program to this quality initiative now to 12 spine surgeons. We prospectively collect outcomes and complications after endoscopic spine surgeries. We're defining benchmarks, outcomes, and pursue quality improvement strategies. And so again, enrollment, we are right now already at 400 patients, collect a lot of data. And again, the compliance is really well. Patients really like this, which gets us to the conclusion. Again, a lot of data, a lot of things here, but going back to the ultrasound, I think that it has allowed us to really assess tissue and tissue quality. It's the very first biomarker for the spinal cord injury that assesses a structure that is still positive, so the tissue that is still viable compared to the tissue that is lost. I think I conveyed it to you that full endoscopic spine surgery provides superior visualization, which is associated with fewer complications. And those future developments of tools and apps are going to advance the field. areas that we have not known so far. So with that, I want to thank everybody for listening. Here is my support. Again, as Rich mentioned, I have an R1 DoD funding, a U19 grant for some of our research, and my laboratory, again, which I tried to name during this talk. So here